Good day, everyone. Our lecture for today is about testicular cancer. The objectives of this lecture are the following: to review the pathway of management and principles in testicular cancer, to review the NCCN, EAU, and AUA guidelines in testicular cancer, to provide post-lecture test questions to test the stock knowledge and lessons learned about testicular cancer based on Campbell's book. The diagnosis of testicular cancer is based on clinical examination of the testis and general examination to rule out enlarged nodes or abdominal masses. Ultrasound of both testes with Doppler should be performed whenever a testicular tumor is suspected. An additional ultrasound of the retroperitoneum is recommended to screen for extensive retroperitoneal metastasis. Ultrasound of both testes should also be performed in patients with retroperitoneal mass and/or elevated tumor serum markers without a palpable scrotal mass. Testicular microlithiasis in the absence of solid mass and risk factors for developing GCT does not confirm an increased risk of malignant neoplasm and does not require further evaluation. Serum tumor markers both before and 5 to 7 days after orchiectomy, AFP and HCG, and LDH. The latter is mandatory in advanced tumors. Patients with normal serum tumor markers, HCG and AFP, and indeterminate findings on physical exam or testicular ultrasound for testicular neoplasm should undergo repeat imaging in 6 to 8 weeks. Prior to definitive management, patients should be counseled about the risk of hypogonadism and infertility and should be offered sperm banking when appropriate. In patients without normal contralateral testes or with known subfertility, these should be considered prior to orchiectomy. Inguinal exploration and orchiectomy with en-bloc removal of testes, tunica albuginea, and spermatic cord. If the diagnosis is not clear, a testicular biopsy is to be taken for histopathological frozen section. Organ-sparing surgery can be attempted in special cases like bilateral tumor or solitary testis. Routine contralateral biopsy for diagnosis of carcinoma in situ should be discussed with the patient and is recommended in high-risk patients with testicular volumes less than 12 ml, a history of cryptorchidism, suspicious intratesticular mass, and age less than 40 years. In patients with newly diagnosed GCT, clinicians must obtain a CT scan of the abdomen and pelvis with IV contrast or MRI if CT is contraindicated. In patients with newly diagnosed GCT, clinician must obtain chest imaging. In the presence of elevated rising post-orchiectomy markers, HCG and AFP, or evidence of metastasis on abdominal or pelvic imaging, chest X-ray or physical exam, a CT chest should be obtained. In patients with clinical stage 1 seminoma, clinicians should preferentially obtain a chest X-ray or over a CT scan. In patients with non-seminomatous germ cell tumor, clinicians may preferentially obtain a CT scan of the chest over a chest X-ray and should prioritize CT chest for those patients recommended to receive adjuvant therapy. In patients with newly diagnosed GCT, clinicians should obtain a PET scan for staging. Patients should be assigned a TNMM category to guide management decisions. Principles in management. Management decisions should be based on imaging obtained within the preceding 4 weeks and serum tumor markers HCG and AFP within the preceding 10 days. Management decisions should be made in a multidisciplinary setting involving experienced clinicians in urology and medical oncology, radiation oncology, pathology, and radiology. Expert review of pathologic specimens should be considered in clinical scenarios where treatment decisions will be impacted. In patients with normal serum tumor markers, HCG and AFP, and equivocal imaging findings for metastases, clinicians may consider repeat imaging in 6 to 8 weeks to clarify the extent of disease prior to making a treatment recommendation. In seminoma, clinicians should recommend surveillance after orchiectomy for patients with stage 1 seminoma. Adjuvant radiotherapy and carboplatin-based chemotherapy are less preferred alternatives. For patients with stage 2A or 2B seminoma with a lymph node less than 3 cm or equal, clinicians should recommend radiation therapy or multi-agent cisplatin-based chemotherapy based on shared decision-making. For patients with 2B seminoma with a lymph node more than 3 cm, chemotherapy is recommended. Non-seminoma management. Clinicians should recommend risk-appropriate multi-agent chemotherapy for patients with non-seminomatous germ cell tumor with elevated and rising post-orchiectomy serum AFP or HCG. Clinicians should recommend surveillance for patients with stage 1A non-seminomatous germ cell tumor, RPLND, or one cycle of bleomycin, etoposide, and cisplatin chemotherapy are effective and appropriate alternative treatment options for patients who decline surveillance or are at risk for non-compliance. For patients with stage 1B non-seminomatous germ cell tumor, clinicians should recommend surveillance, RPLND, or 1 or 2 cycles of bleomycin, etoposide, and cisplatin chemotherapy based on shared decision-making. Patients with stage 1 non-seminomatous germ cell tumor and any secondary somatic malignancy, also known as teratoma, with malignant transformation in the primary tumor at orchiectomy should undergo RPLND. Clinicians should recommend RPLND or chemotherapy for patients with stage 2A non-seminomatous germ cell tumor with normal post-orchiectomy serum AFP and HCG. In patients with clinical stage 2B non-seminomatous germ cell tumor and normal post-orchiectomy serum AFP and HCG, clinicians should recommend risk-appropriate multi-agent chemotherapy. Clinicians may offer RPLND as an alternative to chemotherapy to select patients with clinical stage 2B non-seminomatous germ cell tumor with normal post-orchiectomy serum AFP and HCG. Among patients who are candidates for RPLND, it is recommended clinicians consider referral to an experienced surgeon at a high-volume center. Surgeons with experience in the management of germ cell tumor and expertise in minimally invasive surgery may offer minimally invasive RPLND, acknowledging the lack of long-term data on oncologic outcomes. Primary RPLND should be performed with curative intent in all patients. RPLND should be performed with adherence to anatomical principles regardless of the intent to administer adjuvant chemotherapy. These principles are applied to both open and minimally invasive approaches. Follow-up. The primary aim of follow-up in the first 5 years is the timely diagnosis of recurrent disease in order to be able to treat the patient with curative intent with the least aggressive therapy. Interval between examinations and duration of follow-up should be consistent with the time of maximal risk of recurrence. Tests should be directed at the most likely sites of recurrence and have a good accuracy. The increased risk of second malignancy in the primary site and in other tissues that may have been exposed to the same carcinogens or in which there is epidemiological evidence of increased risk should also guide the selection of the tests. Non-malignant complications of therapy must also be considered. Follow-up for pure seminoma stages 1A and 1B after primary treatment. Although no single follow-up plan is applicable to all patients, the NCCN panel has provided guidance for the follow-up of patients with testicular GCTs for the first 5 years after the completion of therapy. These recommendations may be individualized and extended beyond 5 years at the discretion of the physician. Follow-up strategies for patients with stage 1 seminoma vary according to the treatment modality received by the patient, surveillance versus adjuvant therapy. Follow-up for patients with stage 1 seminoma managed with active surveillance after orchiectomy includes a history and physical examination, with optional measurement of serum tumor markers performed every 3 to 6 months for the first year, every 6 months for the year 2, and every 6 to 12 months for the year 3, and annually for years 4, and markers is optional due to the rarity of marker-only relapse, since post-op patients with elevated markers will also have evidence of relapse on imaging. There is controversy regarding how many imaging studies should be performed in patients on active surveillance. The NCCN panel recommends an abdominal pelvic CT scan with or without contrast at 3, 6, and 12 months during the first year, every 6 months for year 2, every 6 to 12 months for year 3, and then every 12 to 24 months for years 4 and 5. CT is not recommended beyond 5 years unless clinically indicated. The MRI protocol should include visualization of all the nodes that need to be assessed, including the retroperitoneal and pelvic nodes, and should be performed in centers with experience in interpreting MRI results for testicular cancer. The same imaging modality, CT or MRI, should be used throughout the surveillance. Routine chest imaging, including chest X-ray and chest CT with contrast, should be reserved for patients with thoracic symptoms. Follow-up after adjuvant treatment. Follow-up of patients treated with adjuvant therapy, chemotherapy, or RT includes a history and physical examination, with optional measurement of post-orchiectomy serum tumor markers performed every 6 to 12 months for the first 2 years, and annually for years 3, 4, and 5. The NCCN panel recommends performing an abdominal pelvic CT scan with or without contrast annually for the first 3 years only. In select circumstances, an MRI can be considered to replace an abdominal pelvic CT. The MRI protocol should include visualization of the retroperitoneal and pelvic nodes and should be performed in centers with experience in interpreting MRI results for testicular cancer. The same imaging modality should be used throughout the surveillance. Chest X-rays should be obtained only when clinically indicated, and chest CT scans with contrast should be considered for symptomatic patients. CT is not recommended beyond 5 years unless clinically indicated. Relapses are treated according to the should not be treated based upon the elevated LDH level alone. Follow-up for pure seminoma stage 1S. The NCCN panel recommends repeating measurements of serum tumor markers and performing imaging studies, chest, abdominal, pelvic CT with contrast to scan for evaluable disease. Follow-up for pure seminoma stage 2A and non-bulky 2B after primary treatment. The recommended follow-up schedule for patients with stage 2A and non-bulky stage 2B seminoma after RT or chemotherapy includes a history and physical examination with optional measurement of post-orchiectomy serum tumor markers performed every 3 months for year 1 and every 6 months for years 2 through 5. An abdominal pelvic CT scan with contrast is recommended at 3 months and 6 to 12 months for year 1, annually for years 2 and 3, and then as clinically indicated for years 4 and 5. In select circumstances, an MRI can be considered to replace an abdominal pelvic CT. The MRI protocol should include visualization of the retroperitoneal and pelvic nodes and should be performed in centers with experience in interpreting MRI results for testicular cancer. The same imaging modality, CT or MRI, should be used throughout surveillance. The CT is not recommended beyond 5 years unless clinically indicated. Chest X-ray is not recommended every 6 months, or chest X-ray is recommended every 6 months for first 2 years only. Chest X-ray may be used for routine follow-up, but chest CT with contrast is preferred in the presence of thoracic symptoms. Follow-up for pure seminoma bulky stage 2 and stage 3 after chemotherapy. The recommended follow-up schedule for patients with bulky stage 2 or stage 3 seminoma after treatment with chemotherapy includes a history physical examination as well as measurement of serum tumor marker levels every 2 months for year 1, every 3 months for year 2, every 6 months for years 3 and 4, once during year 5. Abdominal pelvic CT scans with contrast are recommended every 4 months for year 1, every 6 months for year 2, annually for years 3 and 4, and then as clinical circumstances, an MRI can be considered to replace an abdominal pelvic CT. The MRI protocol should include visualization of the retroperitoneal and pelvic nodes and should be performed in centers with experience in interpreting MRI results for testicular cancer. The same imaging modality should be used throughout surveillance. The chest X-ray is recommended every 2 months for year 1, every 3 months for year 2, and annually for years 3 through 5. While chest X-ray may be used for routine follow-up, chest CT with contrast is preferred for patients with thoracic symptoms or residual masses or nodules in the chest. Patients with residual masses may require more frequent imaging based on clinical judgment. However, CT is not recommended beyond 5 years unless clinically indicated, since viable tumor cells have been found in tumors more than 3 cm with a negative post-chemotherapy that patients with a residual mass measuring 3 cm and negative PET results after chemotherapy should undergo an abdominal pelvic CT scan with contrast every 6 months for first year and then annually for 5 years. Follow-up for non-seminoma stage 1 without risk factors. The long-term follow-up for stage 1 non-seminoma patients without risk factors includes a history and physical examination, serum tumor marker assessment, abdominal, pelvic CT scan, and chest X-ray. In select circumstances, an MRI can be considered to replace an abdominal and pelvic CT. The MRI protocol should include visualization of the retroperitoneal and pelvic nodes and should be performed in centers with experience interpreting these results. The same imaging modality should be used throughout surveillance. All imaging in this setting is performed with contrast. The frequency of this test varies with primary treatment modality received by the patient. It should be noted that routine chest X-ray may have limited value for detecting relapse in stage 1 non-seminoma patients. Chest X-ray is not indicated in years 3, 4, and 5 for stage 1 non-seminoma patients without risk factors treated with adjuvant BEP or primary RPL-ND. Follow-up for non-seminoma stage 1 with risk factors. The long-term follow-up for stage 1 non-seminoma patients with risk factors includes history and physical exam, serum tumor marker assessment, chest X-ray, and abdominal pelvic CT scan. In select circumstances, an MRI can be considered to replace an abdominal and pelvic CT. The MRI protocol should include visualization of the retroperitoneal and pelvic nodes and should be performed in centers with experience interpreting MRI results for testicular cancer. The same imaging modality should be used throughout surveillance. All imaging in this setting is performed with contrast. Chest X-ray may be used for routine follow-up, but chest CT with contrast is preferred in patients with thoracic symptoms. Follow-up for non-seminoma stage 2A. The long-term follow-up for stage 2A non-seminoma patients includes a history and physical examination, serum tumor marker assessment, chest X-ray, and abdominal pelvic CT. In select circumstances, an MRI can be considered to replace an abdominal pelvic CT. The MRI protocol should include visualization of the retroperitoneal and pelvic nodes and should be performed in centers with experience in interpreting MRI results. The same imaging modality, CT or MRI, should be used throughout surveillance. All imaging in this setting is performed with contrast. The frequency of this test varies with the primary treatment modality and post-surgical management received by the patient. Chest X-ray may be used for routine follow-up, but chest CT with contrast is preferred in patients with thoracic symptoms. Follow-up for non-seminoma stage 2B. The long-term follow-up schedule for stage 2B non-seminoma patients is similar to the follow-up schedule outlined for patients with stage 2A non-seminoma and is dependent upon the primary treatment modality and post-surgical management received by the patient. Follow-up for good, intermediate, and poor risk non-seminoma. The long-term follow-up for patients with good, intermediate, and poor risk non-seminoma after chemotherapy, with or without post-chemotherapy RPL-ND, includes history PE, serum tumor marker assessment, chest X-ray, and abdominal pelvic CT. Patients who have an incomplete response to chemotherapy require more frequent imaging than is outlined in the table. Patients who undergo RPL-ND and are found to have PN0 disease or PN1 pure teratoma need only one CT scan at postoperative month 3 to 4 and then as clinically indicated. In select circumstances, an MRI can be considered to replace an abdominal pelvic CT. All imaging in this setting is performed with contrast. Chest X-ray may be used for routine follow-up, but chest CT with contrast is preferred in patients with thoracic symptoms. Second-line and subsequent therapy for metastatic germ cell tumors. Patients with disease relapse following first-line therapy or those who do not experience a durable complete response to first-line therapy should receive second-line therapy. Patients with recurrent disease who have not been treated with prior chemotherapy should be managed per their risk status. It is preferred by the panel that patients with recurrent non-seminoma be treated at centers with expertise in the management of this disease. Second-line therapy options for patients with early relapses within 2 years of the completion of primary therapy include enrollment in a clinical trial, which is preferred, conventional dose chemotherapy or high-dose chemotherapy. If chemotherapy is given, both conventional dose and high-dose regimens are preferred in this setting. The conventional dose regimens are DIP or high-dose carboplatin plus etoposide followed by paclitaxel plus ifosfamide followed by high-dose carboplatin plus etoposide may be considered if the recurrent mass is a solitary resectable site. After completion of primary therapy, occur in 2 to 3% of testicular cancer survivors for this patient if the unresectable chemotherapy is the preferred option. Clinical trial enrollment is also an option for patients with unresectable late relapses. Third-line therapy. Participation in a clinical trial is the preferred treatment option for patients who experience relapse following first and second-line therapy. Alternatively, patients previously treated with conventional dose chemotherapy can receive high-dose regimens or be considered for surgical salvage if the recurrent mass is in a solitary resectable site. Alternative options for patients previously treated with high-dose regimens include conventional dose salvage chemotherapy, surgical salvage if solitary resectable site, and microsatellite instability mismatch repair MSI-MMR testing if disease progresses after high-dose chemotherapy or third-line therapy. The preferred treatment option for patients who experience a late relapse more than 2 years after completion of second-line therapy is surgical salvage if the recurrent mass is resectable. Conventional dose or high-dose chemotherapy, if not previously received, are also options for patients with relapse. In order to maintain optimal efficacy and limit treatment-related toxicities, the chemotherapy regimens previously received by the patient should be considered when deciding on third-line therapy options. High-dose chemotherapy is the preferred third-line option if it has not been previously received. If high-dose chemotherapy was previously received by the patient, then palliative chemotherapy is the preferred third-line treatment option. Additionally, the panel considers pembrolizumab immunotherapy to be useful in certain circumstances. The recommended third-line palliative chemotherapy options for patients with intensively pretreated cisplatin-resistant or refractory GCTs are combinations of gemcitabine with paclitaxel or gemcitabine and oxaliplatin or GEMOX. Treatment of brain metastases. Brain metastases from testicular GCTs are relatively rare and occur almost exclusively in patients with non-seminoma. Of brain metastases may be more common in patients with higher burden of systemic disease, lung, liver, and/or bone metastases, high levels of serum beta ECG, and in those who experience relapse after cisplatin-based chemotherapy. The prognosis of patients with brain metastases from testicular GCTs is poor, with more than 50% of patients dying within 1 year with additional adverse prognostic factors, especially those with metachronous brain metastases, have even worse outcomes. The optimal management of brain metastases from testicular GCTs is controversial, with a lack of evidence from prospective trials to guide treatment decisions. Therefore, management decisions are usually based on institutional preferences, which may in part explain the large variation in treatment and modalities received by these patients. The NCCN guidelines recommend primary cisplatin-based chemotherapy for patients with brain metastases. The addition of RT to chemotherapy regimens can also be considered. Surgical resection of metastatic brain lesions should be performed if clinically indicated and feasible. Quality of life and long-term toxicities after cure. Patients diagnosed with testicular cancer are usually between 18 and 40 years at diagnosis and life expectancy after cure extends over several decades. Before any treatment is planned, patients should be informed of common long-term toxicities. During follow-up, patients should be screened and treated for known risk factors such as high blood pressure, hyperlipidemia, and testosterone deficiency. When follow-up by the clinical expert is discontinued, a written cancer survivorship plan addressing late toxic effects, lifestyle recommendations, recurrent risks, and cancer-specific follow-up might be helpful.